from Shankar Netralaya, and he's done his MS from Arvind Eye Hospital and has a lot of cataract cases and a lot of corneal cases and refractive cases under his belt.
Thank you so much. Good morning, everyone here. So, when I thank AIOS and Dr. Saiba for giving me this opportunity. So, when Dr. Saiba called me up and said that, Nishanth, you have to talk of the mistakes you have done, I was actually really happy. And she told me, talk only on 3. I was like, just 3 mistakes? I'm sure we all do a lot of mistakes, but it's not about the number of mistakes you do, but how much you learn from it. So, if you have never made any mistakes, we all know that you have never tried anything new. But at the same time, I think you should also know that before trying anything new, make sure you know a lot about the old. Because if anything happens to the new, you should always be able to go back to the old and making it perfect. So, what are the 3 mistakes which I have learned from for my LASIK? I would go in the process of the preoperative mistakes you make, the intraoperative, and the postoperative. So first, let's go about the preoperative, what all we have to see in a patient who's undergoing a LASIK surgery. We all know that we take care of the visual acuity, the autoref value, and the non-contact tonometry. Definitely always do a cyclorefraction and always check for ortho. I have had few of my friends who called me up and said that, Nishanth, after I did the the LASIK, the patient said that the eye is not moving, he's got squint. I said, no, it must have been there before, which we have not evaluated. Being ophthalmologist, including me in the early stages, the first place I see the patient is on the slit lamp. I'll say no. Take a torchlight, look for the ocular movements before you plan for the LASIK surgery. I also see for the dominant eye sometimes to make sure that they are more comfortable in that eye. Definitely make sure that you take care of the tears either by shimmers. I have the Sirius which does the non-invasive technique. And I think the Scheimpflug imaging is the way to go forward. You either have the Pentacam or the Sirius, which you will have to definitely do. And in the Sirius, which I have, which takes a Scheimpflug imaging, I also see the posterior elevation, the non-invasive. And an important factor which I started seeing after my Sirius is the pupillography. So I will talk about that also, and then definitely a bit of an barometry to see for higher order aberrations. Why I'm telling so much about pupillography is the normal optic zone, which I actually keep in my LASIK, is around 6.2. So before, without seeing the pupillography, you just do, and when the patient complains of a glare and halo, you tend to ignore them and you actually try to convince yourself that the patient is only complaining with where he didn't have a problem at all. For example, take this patient. You have a scotopic of 6.47, where I keep my optic zone as 6.2. I'm definitely sure this patient from the first post-op day is going to have a problem of glare, which I cannot ignore. So I started seeing that, and the only thing what I will say is look for the scotopic pupil and always make sure your optic zone is larger than your scotopic pupil. And make sure you have a proper fundus evaluation. Sometimes I don't know how many of us see indirect ophthalmoscopy for all the patients, but to be frank, I don't. I see mostly for my LASIK. My other cataract patients, I actually see with 90 diopter and ask them to look in all gazes. But even people with a low power of -1 or 2, there are chances of them having a tear or any small problem in the periphery. And you know how the patients are, like as they get any problem after the LASIK surgery, it is not because of the power, it's because only of your LASIK. So make sure you see all this and treat them beforehand as well. Now, I've actually gone on to some additional evaluation which I do preoperatively. That is, look for the job profile. Because people come for army, they come for police forces, they come for recruitment. And once they do the laser, and if at all anything happens, then they say that, sir, I was supposed to get 6.6, which you told, and I've got only 6.9. So always ask for the job profile and what is the need for them to get LASIK. Psychological patients. You have a lot of patients who actually want LASIK, but they are a little scared of it. So that means that when you see in the slit lamp itself and you are going to put a dilate drop, they actually move. It's like, sir, what are you doing? So these kinds of patients, make sure that they will be little claustrophobic under the LASIK machine. Make sure that you counsel them. I sometimes ask my sister to hold the patient's hand and make them more comfortable and not shout and yell at them. Always be transparent, because my consent form will definitely have indications of glare, hollows, and dry eye. And to be frank, I do not tell my patients openly that there are chances of glare, halos, and dry eye. Because what I realized later on with time is, once you say a patient that there are chances that you will have, the first complaint they come on the next day is, sir, I have dry eye. once you stop saying that, it's there in the consent form. People read them, they come to me and ask that you have told that there are chances. I said, yes, it's not 100% you are getting, but your tears are pretty fine. So the chances of you getting is little less. But yes, there is always a chance of dryness for these refractive procedures. But I stopped telling patients on their face that there are chances of these three. Inappropriate expectations, that is, it improves their best corrected visual acuity, no need of reading glasses. So I have few patients who I've done and they've come after 5-6 years crossing the age of 40 and they say that, sir, you have taken off my power and now I am not able to read. So now I have started saying all my patients that you will start developing reading glasses, and I've also told them that later on in the age when you start developing cataract, you will develop cataract, because nowadays more than LASIK, it is laser. So for them, cataract is laser correction, glasses is laser correction. So they misuse the word laser. So they think that the laser correction which we do is going to correct their power, their reading, their cataract, so that they don't have any other problem. So I actually tell my patients that the chances of cataract is there. And I do not give them 100% guarantee. I always say that the chances of me giving you is the maximum possible chances, but you can have some problems as well. Let's take an example for this patient. So what is the preoperative problem I had? So you can see that it's a perfectly clear case. There was no problem, anterior, posterior float, everything is fine. Before, this is what I actually did during my surgeries. So just a small enact of what we should not do. So as a surgeon, you come directly, you go, see everything, yeah. You sit and you say, sister, send the patient in, right? So that is how we started before. And then for that patient, I got a residual. So what was this? Why did this happen? So if you look at my OT, just have a close note that I have two ACs. One is the centralized and one is which is wall mounted. During the LASIK, you should all know that it's not the one on top which will actually interfere with the flow of the laser. It should be on the side. And look at the humidity which has happened. This was not checked neither by the staff nor by the doctor. So slowly later on, what is the lesson learned which I did after that? You don't scrub in and go in, you check for the AC, you look for the humidity and you look for the temperature. These are the two main criteria which actually has been not seen properly, and we always tend to blame the sister. Sister, why didn't you see? So now you see that my AC is opened up in the side. So then you check for everything and always try to be the change and try to do the change. So check for the fluence, temperature, humidity, and the foot pedal. I had a time when the suction was on, but my foot pedal was near the sister above the table where they have not kept it in front of my foot pedal. So all these are the practical difficulties which we might face. So even before you sit, make sure that the foot pedal is in the right position, and then the ring size blade you decided, and check for the microchrotome before every patient. Do not let the sister if you have confidence on them, yes, you can teach them, train them, but when you're training them, make sure that you stand beside them where they do 3 or 4 cases without your help as well. So the problems which can happen is inappropriate refraction, incorrect data entry, and mainly humidity and temperature. So I go to my intraoperative. Make sure that you dry the conjunctiva before you have the suction, and mark the cornea with 3 marks which are not equal. And make sure that the limbus is covered 360 degrees. And while the suction is on for the sisters, make sure they press the foot pedal and they take the leg off and they keep it in the side. Make sure that they don't press the foot pedal, and sometimes their leg will be like this, just on the foot pedal. Do not have this, because anytime they can touch it again and all the sister says is, sir, I'm sorry. So make sure that the suction is pressed and the foot is over here. They should not be keeping their leg on the foot pedal. And if you suspect anything, always please stop before anything is abnormal. So this is one case, actually one of my friends, she sent me the video, and just have a look at this. I'm sure everyone must be able to see, as soon as you see it, what do you see? It's a buttonhole. And look now what she's trying to do. So yes, these are the intraoperative problems which you should know which can occur. And what is the best way to actually deal with it? Just reposition the flap back. If you do not know that, that's why I always say stick to the old. What is old? That you have a buttonhole, you put back the flap. And what is new? If you want to try something new. Yes, so she tries to scrape it, and then if it's not coming, she tries to remove it more. And this video was sent in the end. She told me that I have done this, now what do I do? I said, now all you do is just pray. So, and then laser was also done. The flap was also put back. and you can see that central flap. So that's why I always say make sure that you know what it is. So this is a case where I think the patient was moving a lot, so the patient had difficulty with the suction. I mean the doctor had. So what he told me was the patient was not listening to me. I said always make sure that they're comfortable without forcing them. Look, again and again and again he's trying it to make sure that they clear. And once you take the suction, you can see that inferior part is not covered. Inferior part, you can see that so much of conjunctival exposure, and then there is severe amount of bleeding. And now look what happens. So you have the flap which was cut over there. But because he knew what to be done, and this was a retina consultant who came to my LASIK center, he was able to manage. He just lifted the flap back slowly, did the laser, put the flap back with some saline, made sure that the bleeding was stopped. Because of the mark, he was able to align them, and it was not at all a difficult. Then finally BCL. So this is how you manage when you know intraoperatively. And post-operatively, always go and meet the patient as soon as you finish, because there you will be able to give the comfort to the patient and the attender that everything went on well. Don't make your assistant go meet them. You can grade their pain scale over there in the room itself. So if you feel that the pain was little more, you actually give them a tablet of a painkiller before you see them in your OP downstairs. And always have a slit lamp evaluation. I will never switch off my laser machine unless and otherwise my patient leaves my hospital, because after the slit lamp evaluation, I've actually had to go back to the theater because sometimes the patient squeezes a lot. You can see here that the flap is folded. It is not something to worry about. It is not something which is a problem. Just make sure that you see that down, and all you have to do is just inject some saline, reposition the flap, make sure that you wash the interface, and put a bandage contact lens. These are the patients where their orbicularis muscle will be very tight and firm. So there is no harm in taking them back to the operation theater. And give proper instructions to all the patients. And I have realized that this is, I put the first drop myself. That is, I just open the Predford, I put one lubricant gel, and they feel that, okay, the doctor has put the drop themselves. And I also teach the attender how to apply them. And post-operatively, I always see both eyes vision. I do not see single eye vision for my LASIK patients, please. And to summarize, I will say cross-check everything yourself. Have a checklist. So when I get into my theater, now you will actually find every day I go into my theater, it is the humidity, temperature, AC. So when you start doing this, your sister knows that, okay, this is the protocol which is going to be there, and you don't miss any step. So don't skip any step. Okay, today let me not check the microkeratome. I'm sure it must be working well. Please do not do that. And there is always someone to blame for the mistakes that happen. Yourself. Take the blame always, because the patients are not going to blame your sisters or staff for all the problems which had the OT. So you should know that it is always you yourself who is going to be blamed. So if you know that, you will make sure that you are more safe for it. So all of you go make mistakes, but learn from them. Thank you.
Thank you, Nishanth, for making those mistakes. Uh, while Saiba is setting up, do we have any question for Nishanth? So I think you were quite clear. How many of us young ophthalmologists are performing refractive surgery? Did you relate with him? Did you relate with his talk?
Yeah, absolutely. Because as a part of fellowship, we're not really taught about the practicalities of doing LASIK, and